Hypertension in the young. Welcome to our clinical deep dive, where today we unpack the important topic of high blood pressure in young adults. This typically refers to individuals under the age of 40, but some guidelines extend this category to those under 55 years old. The growing prevalence of hypertension in this age group is not only concerning but demands a careful, systematic approach to diagnosis and management. Unlike older adults, where most cases are classified as essential or primary hypertension, younger adults are more likely to have an identifiable secondary cause for their elevated blood pressure. This means that a thorough investigation is not just helpful, but crucial. Let us walk through, in a structured manner, the causes and the recommended approach to evaluating high blood pressure in young adults. Causes of hypertension in the young. The causes of high blood pressure in young adults can be broadly divided into two categories: essential or primary hypertension and secondary hypertension. It is especially important in younger patients to consider the secondary causes, particularly if the high blood pressure is severe, difficult to control, or has developed abruptly. Essential, primary, hypertension, pathogenesis. This form of high blood pressure arises from a combination of genetic predisposition, lifestyle influences, and early onset metabolic challenges. Key contributing factors: common obesity and metabolic syndrome. The leading driver of this phenomenon in young people: sedentary lifestyle and poor diet, high salt intake, low potassium, and excessive alcohol consumption act as significant risks. Family history. A strong genetic link often exists. Obstructive sleep apnea. This condition is increasingly recognized as a significant contributor, even among those who are not overweight. Chronic stress. Secondary hypertension. More common in young adults. Secondary hypertension means there is a specific, often treatable, underlying cause. A helpful way to remember these is with the mnemonic ABCDEFG. A. Aortic coarctation. A classic cause seen in children and young adults. It presents as high blood pressure in the arms with weak or delayed pulses in the legs. B. Renal or bilateral renal artery stenosis. In young people, this is often the result of fibromuscular dysplasia, particularly in women. Atherosclerotic causes are less common in this age group. C. Catecholamines and cortisol. Pheochromocytoma or paraganglioma. These are rare, hazardous tumors causing episodic spikes in blood pressure, often with classic symptoms such as headaches, sweating, and palpitations. Cushing's syndrome. This condition results from excess glucocorticoids. Primary hyperaldosteronism. Conn's syndrome. This often presents with low potassium and difficult to treat hypertension. D. Drugs and endocrine. Drugs. Common culprits include stimulants such as those used for attention deficit hyperactivity disorder, cocaine, amphetamines, non-steroidal anti-inflammatory medications, oral contraceptives, steroids, decongestants, certain herbal supplements, and erythropoietin. Endocrine. Overactive or underactive thyroid function can also elevate blood pressure. E. Essential hypertension. This is a diagnosis made only after other causes have been excluded. F. Renal parenchymal disease. This is actually the most common secondary cause in young adults, including conditions like chronic glomerulonephritis, reflux nephropathy, and polycystic kidney disease. G. Glaucoma and genetic causes. While glaucoma does not cause systemic hypertension, the G can stand for genetic causes such as Liddle syndrome and Gordon's syndrome. Workup for hypertension in the young. The evaluation of high blood pressure in young adults must achieve three main objectives. First, confirm the diagnosis with precision. Second, assess for any damage to organs that may have occurred as a result of high blood pressure. And third, identify any secondary causes. Step 1. Accurate diagnosis and initial assessment. Proper blood pressure measurement. Confirm the diagnosis using blood pressure measurements recorded outside the clinic, such as ambulatory blood pressure monitoring, to rule out the so-called white coat effect, which is common in younger individuals. Detailed history, personal and family information. Ask about age of onset, how long the high blood pressure has been present, and any family history of hypertension or early cardiovascular disease. Symptoms suggestive of secondary causes. Look for muscle weakness, which may indicate low potassium from aldosteronism. Episodes of palpitations, sweating, or headaches, which could signal pheochromocytoma. Loud snoring or daytime sleepiness, suggesting sleep apnea, and leg pain when walking, which may indicate aortic coarctation. Medication and drug review. Review all prescription and over-the-counter medications, recreational substances, supplements, and hormonal contraceptives. Physical examination. Blood pressure in both arms and one leg. This helps screen for coarctation of the aorta. Eye examination. Fundoscopy. Look for changes seen with high blood pressure in the retina. Auscultation. Listen for abnormal sounds, broods, over the kidneys that might suggest renal artery narrowing. Signs of endocrine disease. Look for features such as a rounded face and central body obesity, suggesting Cushing's syndrome, an enlarged thyroid, or skin lumps, neurofibromas, that may be linked to rare tumors. Step 2. Routine laboratory and basic testing for all patients. Basic metabolic panel. This includes sodium, potassium, creatinine, and bicarbonate. Low potassium can be a clue for primary hyperaldosteronism. Lipid profile and fasting glucose or glycated hemoglobin. These help assess the patient's overall cardiovascular risk. Complete blood count and urinalysis. These tests screen for kidney involvement, looking for evidence of protein, blood, or abnormal particles in the urine. Renal ultrasound. This imaging test checks the kidney's size and structure, searching for cysts or scarring. Electrocardiogram. This is used to look for thickening of the heart muscle, a sign of organ damage from high blood pressure. Step 3. Targeted testing for secondary causes. Based on clinical suspicion. High clinical suspicion may be raised by age under 30, very high blood pressure that is hard to control despite 3 or more medications, sudden onset, low potassium, abnormal kidney function, or findings on examination that point to a specific cause. Specific tests. Renovascular disease, renal artery stenosis. Doppler ultrasound provides a good screen, while computed tomography angiography or magnetic resonance angiography can confirm the diagnosis. Catheter-based angiography is the gold standard and allows for simultaneous intervention, especially in fibromuscular dysplasia. Primary aldosteronism. Screening is performed with the plasma aldosterone concentration to plasma renin activity ratio. Interfering medications should be withheld if possible. Pheochromocytoma. Screening is best done with plasma-free or 24-hour urinary fractionated metanephrenes, which are highly sensitive and specific. Cushing's syndrome. Use the overnight dexamethasone suppression test or a 24-hour urinary cortisol measurement. Coarctation of the aorta. Echocardiography is a good initial test, with computed tomography or magnetic resonance angiography providing a definitive diagnosis. Obstructive sleep apnea. Order a sleep study if clinical suspicion is high. Step 4. Assessment of target organ damage. Echocardiography. This test is more sensitive than the electrocardiogram for detecting left ventricular hypertrophy and diastolic dysfunction. Retinal examination. Specialist evaluation by an ophthalmologist may be indicated. Summary and clinical approach. 1. First, consider secondary causes. In a young patient with high blood pressure, always maintain a high level of suspicion for a treatable secondary cause. 2. Rule out errors and lifestyle causes. Confirm the diagnosis with ambulatory blood pressure monitoring. Take a detailed medication and substance history, and evaluate for obesity and metabolic syndrome. 3. Start with a broad, basic workup. Begin with a thorough history, physical examination, basic laboratory tests, and renal ultrasound, as these often provide initial clues such as low potassium or differences in kidney size. 4. Pursue targeted testing. Order specific hormonal and vascular tests when clinical clues point toward certain diagnoses. Measurement of the aldosterone-renin ratio and metanephrenes are essential in cases that are difficult to treat or particularly severe. 5. Obstructive sleep apnea should not be overlooked. This is a very common and often missed contributor to high blood pressure in young adults. To close, identifying and addressing the underlying cause of high blood pressure in young adults can, in many cases, lead to a cure, avoid the need for lifelong medication, and substantially reduce long-term cardiovascular risks. A systematic and comprehensive evaluation is essential for the best outcomes.